join us in welcoming all of our speakers today. I'll pass it on to Dr. Zia.
Thank you, Miranda and Jasmine. So I'm going to open us up and just hear a little bit more about your own personal stories, knowing that our theme today is really just trying to make sense of suffering. How do you personally define suffering? And what kind of stories do you have that can actually help clue us into how that profoundly shaped how you think about suffering? Let's start with you, Lydia.
All right. Hello, great to be with you all. It is such a joy to be someplace so sunny and beautiful, so thanks for having us. So suffering, I am a primary care doctor, and I also see patients in the hospital. So I generally take care of aging and older patients on the whole who are quite sick. So suffering manifests quite a bit in that regard. And I would say before I went to medical school, when I thought about the suffering of the sick, I thought about disease. And maybe a little bit of depression and anxiety, and then you learn a little bit more about mental illness, and maybe a little bit more mental illness thrown in there. But I think now at this point in my career, I think of suffering much more broadly. So sort of any kind of pain or anguish, right? It could be physical, it could be mental, or psychic, or spiritual, or relational, or emotional. I think all of those different categories can be places where we see suffering. There's a philosopher, Alvin Plantinga, and he talks about the distinction between sort of suffering that I just described and evil. And he says, you know, if you look at the world, you can see some things that just don't seem right in the world, that seem like they're caused by evil or bad forces or whatever it might be. Some of that can cause suffering, but he distinguishes between the two. And then just one other sort of category of suffering I'll throw out. So evil can cause suffering, but maybe not all evil is suffering. Suffering, I'm saying, is sort of pain or anguish of all different kinds. And then there's another scholar who talks about chaos as causing a kind of suffering. And here you could think about everything from the chaos of what is true in the media to the chaos of a 20-car pileup on the highway in a blizzard, right? Some chaos like that can cause suffering, but not all of it does. So I sort of put all that together. When I think of suffering, when I was thinking about these questions and thinking about our event today, I thought of a patient of mine I took care of many, many years ago. And maybe I'll change a couple of identifiers just for the sake of patient confidentiality, but I'll just say she was a woman in her 30s who was pregnant with her fourth child from the father of her third child, who was not the father of her first or second child. And what she said to me is she came in because he really wanted her to get an abortion, and she was struggling with that. She didn't think she could keep the child. She didn't know how she would be able to afford the child. She didn't necessarily want to get an abortion either. And she said to me, you know, doctor, what I really want is I would like him to marry me. But in my community, you kind of don't expect the men to get married to you. And it was interesting, just as we talked, and she was in a lot of physical pain at the time. She was having this profound emotional suffering, deep relational suffering, sort of many different levels. She was brought up in a religious context and it was still kind of haunting her, but she'd walked away. So there was a little bit of religious or spiritual suffering. So many different levels of suffering. And I thought of her as I was thinking of this question because she seemed to sort of embody these many different kinds of suffering that we see in medicine and kinds of suffering that as my career has gone along, I've seen, it's just more than your physical illness. So I'll leave it there.
I find it fascinating that you actually, I think one of the things that really has stood out is this concept of also thinking about relational suffering. So often we're really thinking about the physical, the emotional, and maybe just in the moment related to the mental suffering, as opposed to thinking about that from a holistic perspective. So thank you for that.
Well, that was a great answer. I'll add, first of all, in prepping for this, I thought a bit about suffering, and I like the word anguish. To me, that's the really active verb that you used and that really resonates with me. So when I think of suffering, I think of people experiencing anguish. I guess it can be relational, it can be due to a variety of things, but I really want to make the distinction between pain and suffering. I've had, many patients with severe, incredible pain, psychic, relational, whatnot, who are not suffering. And then others who seemingly don't have nearly as bad a pain, but are suffering tremendously. So for me, that was the operator in there, is this notion of the anguish. So when I see patients that are in anguish, or family members that are in anguish, they're really, really tortured by their predicament, that's when I really think of suffering. And, I was asked to think of a case, and it might take a sec, but there was a case many years ago when I was a young student, and there was a complicated guy who'd had a gunshot wound to his chest, left him paraplegic, had a tremendously complicated medical story, and I was a medical student, and so I was charged with, taking the whole history and presenting it to my attending, and I got to say, I nailed it. I knew everything. This guy had been sick for 15 years after his gunshot wound, had everything in the world wrong with him. I knew every date of everything, and then the attending lifted up his belt and he saw a scar, and he's like, "What's that?" It was an appendicitis scar from 1978, which I knew, but I hadn't brought up. So I said that, and that was sort of my crowning glory, as I had answered every conceivable question about this person. He was there with his wife. Everybody was impressed. There was applause. I leave. Whatever. Over the years, he would come back a few times, and unfortunately, he broke up with his wife and seemed to, and I saw him several times over the years. And the last time I saw him, I was finishing residency, came in the middle of the night via ambulance, and he was, at that point, a torso. He had lost both legs at the level of the pelvis due to decubitus ulcers and all of these kinds of things. He'd fallen into this really horrible state of, humanity, almost the worst you can imagine. And he was put into a room in the back, and basically everybody just sort of gasped and did not provide him the kind of dignified care that I would have expected. Now, I knew him from before. So I saw the same guy, but my nurses, my other colleagues were just sort of looking at him like he was below the level of humanity. And in that, I understood real suffering. He suffered pain, he'd suffered all these medical complications, but, honestly, the worst of it that I saw was the suffering, the loss of dignity at the end of his life. And that really stuck with me, that notion right there. He did die during that hospital admission. He was really sick at that point. But I really felt that we had, as a community, not necessarily even a community of healthcare providers, but as a broader community, have really failed to relieve his suffering. And for the record, he was shot, just not that it matters, but working at a convenience store that was robbed. So, but I think by the time he got to that state, people just sort of looked at him as some guy who got shot, lost all his limbs, and now he's just somebody we have to put IVs into, and I really don't want to. And it was awful.
Mm-hmm. Wow. Thank you for sharing that. As I was thinking about how I would respond to the next question about how, as physicians, how our understanding of suffering has changed over the years, I think, Mike, you kind of hit the nail on the head, because the two phrases that I think about, or the one phrase that I think about associated with suffering, is dignity, and providing that sense of dignity in an effort to help alleviate my perception of what suffering can entail. I think in so many ways I've seen patients on the adult side on the pediatric side, and there's so many different layers of the suffering. Is it the suffering of the child? Is it suffering of the patient? Is it suffering of the parent? Is it suffering of the family members or the caretakers? And one of the things that still rings true in any time that, especially when I'm thinking about suffering at the end of life, I'm always reminded about how do we actually help provide that support and that sense of dignity and respect to the people who are involved. So now I ask each of you, how has your understanding of suffering changed over the years?
Well, I suppose I sort of alluded to it in my earlier remarks, which is that I think it's become a much more complicated understanding of suffering. Well, certainly going into medicine, I thought it was kind of sickness and sickness-related stuff. But the more you get to know patients, and especially walking alongside patients for the long term, and as a primary care doctor, but certainly when you have patients come back again and again and again in any clinical context, you follow their stories over time and you realize just how complicated lives are. Some friends, medical friends of mine, and I often joke that you can't make up the stuff we see in medicine. The stories are extraordinary, and to walk with people who've experienced so much over time, you see how just complex it is. Can I, before Mike answers, can I ask you a question? Maybe you can include into however you want to respond. But I was curious about your statement that people can be in pain, but you wouldn't call that suffering. And I was wondering if you could say more, because every time I experience pain, I think I also suffer, just a little bit.
I'll respond to yours first. So actually, I think a forthcoming question might get into this a little bit. I have just seen patients who have physical pain, undeniable physical pain, broken bones, where I don't see the anguish that I see with some others. And I'll just say right now, I had this shift some number of years ago where I had this woman. She was an African-American woman born with osteogenesis imperfecta. So she was like mid-50s or so. So she had been through her life. And she was about 3.5 feet tall because she'd had 1 million fractures while growing up. And she had, gotten out of bed. I can't remember the details or something. And her femur broke. Right? I mean, she did nothing and it broke. And she was just one of the most pleasant, happy people I'd ever met in my life. And her family came to her bedside. They'd been through this 1 million times before, and there was no pity. There was no anguish. There was, oh, you did it again. Now we got to figure out how we're going to do this. And they were laughing. And it was, I'm not saying it was a joyful experience by any stretch of the imagination, but it wasn't full of anguish and horror that one might expect this woman who lived 55 years with, totally, largely disabled, breaking bones, like hundreds of times. She had an in utero fetal fracture. That's how they diagnosed her, So, that really stuck with me because at the same time I was seeing another patient who was a well-to-do Newport Beach person who had, that's just where I was working at the time. And she was experiencing, it was some form of chronic pain syndrome, that was in the chronic low back pain, fibromyalgia spectrum. And this is back in the day when, that was treated with opioids. And she was suffering. She was really suffering from this condition that, from a medical perspective, there was little to do. There was, I could throw some more opioids at it, and that's sort of probably what I did at the time. I'm not sure. But the point was I had this juxtaposition, these two people that had totally different responses to pain, and one where there was a little bit of a community that rallied around them and it made it really a sort of fun bedside to be at, and the other, which was the bedside that everybody tries to avoid with a 10-foot pole because it's this vortex of anguish and despair that doesn't have a treatment and whatnot. So that's sort of where how I see the distinction between suffering and pain, if that makes sense. And then the remainder of the question was...
It's interesting, though, because we know that people who are deeply embedded in communities that care for them tend to feel their pain less intensely. But people who are isolated tend to feel their pain more. So actually, it may be that if there's some way that we could truly quantitate the pain with some sort of AI, I don't know, AI is going to do everything, but, that we might find it's the same number.
We might.
But the experience of the pain is very different because the one woman is so supported by her community. I don't know. It's just interesting because suffering's so complicated.
It's obviously a really complicated concept. Hence why we're here.
Well, and I think I'm curious then, given that observation you've made, Lydia, what kind of examples do the two of you have where you have noticed something along the lines of having that community, having that village, being isolated, and how that impacts suffering or your perception or your observation thereof as you've encountered others or patients?
Yeah, I mean, a lot of examples come to mind. So I think, the med students will know this. Who's most likely to die by suicide, right? It's the single older white man who is alone. That's the highest demographic, right? Every single patient comes into primary care, and what do they say to me? My pain is worse at night. Why is your pain worse at night? You're lying alone in your bed. You're distracted by nothing. There's no one around you who needs you, right? It's you and your pain. Things like depression and anxiety, patients who are also diagnosed with depression and anxiety and have a reason to have physical pain, their physical pain is worse with the depression and anxiety. So I'm just thinking of a lot of examples like that come to mind. I don't know if anything strikes you, Mike.
I can't. This was an example, I think, that sort of typified what I was talking about. When people are around a patient, it's very clear to me that there's a reduction in stress levels to the point, even to the extreme, right? You're in med peds, you're in primary care, that when we have children that are in extremis, it feels like the general suffering of the room goes down when their parents there, when their family members are there, even when you have children that are dying, right, literally. And there, in those circumstances, for all of you, there's a lot of suffering going around with the physicians and the nursing staff that are, there's a lot going on there. And usually bringing the parents in, bringing people that we know loved those people, gives us all some sense of comfort. It's not perfect, obviously, but it's something. And I did want to, this feels kind of dark right now, so I'm going to liven it and say, going back to this sort of suffering and dignity thing, one of the things I've learned about, all of this is that because, for me, suffering has a lot of associations with lack of dignity and respect, I think, it's actually something that you can give back to a patient pretty easily. So if there's a positive, that would probably be one of them, right? Like you can actually you can't fully restore someone's dignity if it's been gone been taken from them for many, many years. But as a student, as a medical student, as a physician, you do actually have a tremendous amount of power to restore dignity when you talk to patients and their families. And that's something that I really hope that people take from this.
Yeah, well, and that, speaking of the nature of suffering, let's kind of get into it a little bit more. I think our natural inclination as physicians or physicians in training is to fix and to take away the suffering, but that's not always necessarily the answer. So what are some of the circumstances in which you've actually embraced suffering rather than tried to avoid it, particularly when it comes to helping your patients or other people face significant illness or death?
So I don't like the language of embrace suffering. I felt myself sort of bristle when you said that. I know that there are some spiritual traditions where people, it's kind of like taking vows of poverty. People will sort of seek out suffering for some sort of religious or spiritual purification, and I'm not an advocate of that. I feel like there's enough suffering in this world; it will come find you. having said that, so not embrace suffering, but not run from it. So when I think about suffering, I think that there tend to be three responses. I don't know if this is accurate or not. I'm kind of making it up. But there are people who seek suffering out. I think they're very much the minority. Well, let's say they're 4, so that's very much the minority. But then there are people who do look into suffering. And I think there are doctors, and you'll see these doctors, I think, as mentors who actually really accompany the one who suffers. That they don't try to avoid patients who are suffering. I mean, your description of the woman with the fibromyalgia, the sort of pain syndrome, especially at the time, right, when we took these much less seriously. Long COVID has helped us understand some of these pain syndromes better, a little bit. But there was a time in medical practice where we really kind of poo-pooed these sort of pain syndromes and made light of them. And, we can't find anything on imaging anyway. It must be in your head. There was a period of medical history where that was the way patients were treated. So I think there are the people who will sort of look intently, gaze with great dignity, bringing out the dignity of their patients, really accompany their patients through the suffering. And then there are people who sort of see the suffering and just try to walk along the side of it, right? And then there are people who run from suffering. And I will tell you that there are times, even though I would like to think of myself as always being someone who does not abandon my patient and doesn't try to walk too far away from them in their suffering, there are times for self-preservation in medicine when you cannot give the fullness of yourself to a patient. You just can't. And you have to be selective about which patients really need you. But I think being mindful that there's going to be a human impulse to try to avoid the suffering. Remember that, because your patients are still suffering. And so you don't want to be the one who kind of walks to the side. You still want to sort of press in with them to the suffering, not embracing it, but not abandoning them, not abandoning the ones who suffer. Navigating through it, yeah. Sort of with a bit of a moral courage, I would say, to like, yes, it's ugly, yes, it's painful. Nobody wants to sit there. But patients also want to have a clinician accompany them through it.
Yeah, well, and we know that you have authored a book, The Lost Art of Dying, in which you kind of speak to features that can help shape a good death. Mm-hmm. What message would you give to our students and to the people who are sitting here today?
Yeah, I mean, I guess it's a little bit similar. I mean, in the book and in a lot of my work, I've talked about the need to acknowledge our finitude, so our finiteness as human beings. So, in a sense, that's a parallel to suffering, right? Every single one of us will suffer. Every single one of our patients will suffer. Suffering is a part of life. Martin Luther King Jr. said once, he was talking about the weeping prophet Jeremiah, and he was talking about how Jeremiah stared his anguish in the face, and he bore it. He bore his anguish, and I think that's kind of the challenge. It's not to seek it out. We don't want to embrace it, but we also need to bear it. We need to look suffering in the face and figure out how we're going to go on. And I think the same thing is true with our finitude, our finiteness. All of us are going to die. Mortality, it's 100%. It was 100% last year, right? I mean, the statistics are the same. There's 100% mortality. And so in light of that, it's not that we seek it out. We don't fixate on it. It's not, I mean, if you want to go to death cafes, that's fine, but that's not the point. The point is, okay, mortality is 100%. What do I need to do to prepare? I saw some quizzical looks about the death cafes. It's like a thing your generation is into, where people go and like hang out and drink wine and talk about death. If you want to do that, that's fine. There's no judgment. No judgment. It is a thing. It's a movement.
Interesting. Very interesting. Well, Mike, what are some of your thoughts on how to navigate through suffering without avoiding it?
Oh, well, first of all, a lot of what you said really resonates. I think one of the big jobs of a physician is to bear witness. There are things we can fix, As I get older, I realize there are fewer and fewer of them. Despite medical progress, somehow there's less. When I look at and I think that reflects me viewing people with that life, 100% mortality. That is true. So I see things less and less over time as a series of problems that need to be fixed, with some notion that if you do that long enough, then people will live forever or whatever. And so now I see things a little differently, and I see, people who, for lack of a better term, are suffering, and I can maybe help in some context. I can't fix things. There's some things I can fix, and a little elbow or something like that, I can actually fix that. But fewer and fewer as I get older and older are things that I can actually fix. So I think that one of the big things is to recognize our role in this space, which in my opinion is fix what can be fixed, relieve pain that can be relieved, whether that's physical pain, emotional pain, or whatever, and then bear witness and tell people, let them know, there is nothing more that can be done. From a medical perspective, there's nothing more. And I feel that most physicians are really uncomfortable with that, going there, and they will not do it until you've failed 9 rounds of chemotherapy and you've had all of these different things, and say, wow, this is incredible that this person has been put through this much, when the writing, it was really on the wall a year ago, and they could have been much more prepared for their end. And I, as an emergency physician, see a lot of these people coming into the emergency department, when any sane physician would be like, oh my God, this person is so close to death and has been for a long time, and their families are completely stunned when I start to bring this up, because she was just getting chemotherapy yesterday, and there's an 85-pound woman who's had metastatic disease for years and years and years, and they're just totally ill prepared. And I think it's because so many physicians are unwilling to sort of go there and just even be in that space at all. I don't know if it's because it's uncomfortable, we're ill-trained, or it's in our sort of biomedical world, that's admitting defeat. Oh, well, if we give up on, if I say there's nothing more that can be done, you can't, cancer has won and I'm a bad doctor. Of course, that's not the case at all. And one of the key things to do is to be able to give that guidance to patients as they move through their treatment, whether it's fundamentally at the end going to result in death, or has a potential for actually resulting in cure. And so, I don't know, that's sort of where I would land on that.
Yeah. It reminds me of a colleague, Jeff Bishop, who's a physician and a philosopher. He says, and I'm saying this to the med students in the room because just note the language. Medicine is about doing and not about thinking, right? We do. What's the next thing we do?
Right.
Patient presents this way, we do. And it's really, it's so hard in medicine, because the clock is always ticking, to stop and say, wait a second, she's 85 pounds. Mm-hmm. She's 90 years old. Yeah. Mm-hmm. She has metastatic cancer everywhere. What are we doing, right? Mm-hmm. And you have to stop doing and start thinking. And I challenge you in the room to identify those times when something seems off. Be willing to put on the brakes. Don't write another prescription, but think about what is the context for this patient, and what does care mean now? Care doesn't always mean entering an order into the electronic medical record, but that's the way we tend to practice. Care sometimes means having that conversation and helping families put the situation in perspective. And that goes a long way to alleviating suffering.
Oh, it's unbelievable. Yes. And you might think, again, as an emergency physician, you'd be like, how could this really, I am not joking. This happens almost on a daily basis, where someone comes in who's in this sort of a state and no one's ever had the conversation. And when I see them come in, the first thing I say, we're not doing anything until I get a hold of a family member right now. That's an emergency from my perspective. I need to get a hold of somebody immediately. We need to start having a real conversation about what we're trying to accomplish in the care of this person. It's very easy for me to intubate them and put central lines in them and do these kinds of things. And in fact, I'm compensated well when I do those kinds of things. So there's a huge paradox there. And I get very little additional compensation for, making 9 phone calls to people all over the country and getting, all that kind of stuff. You just don't do it. So you can see how this our practice pattern evolves. We're compensated for doing these things. It's uncomfortable to do it. We're not well trained in doing it. And nobody will say anything bad about your care if you intubate, put the central line in, do all these things. And in fact, your colleagues, eventually you'll see that they'll also do more procedures on those folks. And what you've done at the end of the day, though, is, turn this person who does deserve dignity towards the end of their life into not a pincushion or anything like that. I don't want to be so cynical, but you've really reduced them to a series of problems that individually may or may not be able to be fixed in the short term, but in the big picture, the holistic picture obviously can't. And so when you look at it that way, it's almost unethical to proceed down that pathway because you're inflicting a lot of harm on folks without any potential for sort of long-term gain.
Well, and it's interesting because I'm often at the receiving end when you admit the patient to the hospitalist service, right? And I think on one hand, I'm always so appreciative. On one hand, I'm like, why is this person here in the hospital? There's nothing we can do for them, right? But then on the other hand, I appreciate that there wasn't more done. Because then we're kind of stuck with okay, well, now they're on a ventilator, and now these are the options that we have, as opposed to being able to take that step back, just like you were saying, and to really see that patient as a person, not just the diagnosis, not just everything that they've come in with, and really just take on that perspective of, wow, what are they going through? Is this really what's in their best interest? Because kind of going back to that whole concept of first do no harm, I think I always ask myself, am I causing more pain, physical? Am I causing more anguish? Am I causing more suffering because of the things that I'm doing to this person to try to make them better? Has there been that conversation about what does quality of life mean to you? And what does that dignity look like for you? Do you want to go full court press up until your last dying day or your last breath? Or do you want to be able to say, enough is enough because my body and my mind have it's enough, and I just want to be able to spend the rest of the time I have surrounded by the people I love.
Can I just add on to that just for a sec? So one of the things that I've learned, my greatest moments in medicine have been, some of them have been really cool, resuscitation and stuff like that, but some of them have been related to these conversations. And before I did emergency medicine, I actually trained as an internist, so I spent a lot of time in ICUs doing these kind of family talks. But in emergency medicine, whether or in the ICU, there's this commonality where I feel like often we'll ask the family, what do you want to do? Do you want us to do everything or nothing? Or do you want us to let her die? Right? That's sort of how it's framed. And they're like, we have to decide right now because she's not breathing. They're like, well, do everything. And what I've found is that as a physician and actually being able to diagnose and see the whole picture, when you can see it, you can't always. You sometimes, especially in emergency medicine, you don't always have all the components you need, but very often you do. You can offer a real medical opinion about this and say, it is my recommendation that we not pursue this because there is no or next to no probability that she can recover to a state that even resembles where she was yesterday, much less to a state where she would want to be from 25 years ago. And what's remarkable, I would say, I can't ever remember this not being true, maybe once, you see the family members just relax and they're like, that's what she would want.
Because it's not their decision. They don't feel like they have to hold responsibility for saying stop.
Well, I'm giving and it's still their decision.
Yeah.
But I'm giving my real medical opinion, not a, what do you want us to do? Nothing or something. That's a real, I feel, cop out.
I think this is worth stating. I agree fully with both of what you said. With the movement toward deference to patient autonomy, which are all of you first years or have some of you been on the wards? Any wards? Not much wards. You will find when you are on the wards that the residents do a whole lot of kind of, what do you want? As if As if the patient and their family went to medical school and studied human anatomy and pathophysiology and pharmacology, right? As if, right? And so, but what I would suggest to all of you is that what we're thinking is regarding the patient's wishes is actually an abdication of our own responsibility as physicians, right? When we put too much on patients and we expect patients to make decisions as if they had been through medical training, we are actually abdicating our own responsibility. And so what Mike just demonstrated in this scenario is actually taking responsibility as a physician to give the best medical opinion you can based on the facts and how you understand the situation. And we need to do more of that because there's a whole lot of doctors not actually taking responsibility for patient care, but just dumping data on patients and their families and expecting them to sort of pick up the pieces and choose. And that's not good medicine.
And it results in these bizarro things that you will soon experience when you see like these pulse or these end-of-life order sets, where it's like you can do compressions, but you can't intubate, but you can do vasopressors, but you can't do this.
But
because,
don't feed me.
But don't. Yeah, it makes no sense. It's obvious that they put way too much information on a patient/family member who then was looking through this list and trying to make sense of it, but wasn't actually understanding in any way what we're talking about. We're talking about aggressive measures. You can't have one without the other, but you see these checklists, and they're signed and they're countersigned by a doctor. And you're like, how could you, this is giving people no useful information. It implies that you didn't do your job very well because they should either all be checked or none of them be checked, essentially. Anyway.
Well, and thinking about healthcare and society in the context of suffering, where do you think our medical system has succeeded or failed in addressing human suffering? I know it's a big question.
Yeah. I think probably the biggest lie in medicine is the idea that there is a fix for everything. So there's this old adage that I think has been misattributed to sort of every famous person who's ever been a doctor, that medicine, that we cure, we cure sometimes, we treat often, and we comfort always. And we have it completely inverted. We think we need to cure always, treat sometimes, and comfort if you have extra time before you go home, and maybe you can get reimbursed for it because there are some, billing codes for existential distress or whatever. So
I mean, there really are.
I do use those. But so we kind of have it, and I think this is where medicine has really failed. This, and I mentioned before that medicine is about doing and not thinking, right? This idea that we have to do, when sometimes what's required of us is to just be, to accompany, to bear witness, to hold hands. I have a number of very elderly patients who come see me far too often at their insistence, and I know they're just coming for hugs and kisses. And I give them hugs and kisses because I know they live alone, they don't have anybody, and what they're coming is for human contact. And I can be a human being with them and listen to them and talk with them and bear witness to this stage of their lives when they're quite on their own. So anyway, what medicine needs to do better, I think, is to comfort always, and maybe treat and aim for cure a little bit less.
Yeah, I mean, I think that's really well said. I don't want to be, throw the baby out with the bathwater. I mean, there are things that we can do. We can extend lives through, a whole host of surgical techniques, medical techniques. There's no doubt about that. So medicine has done well in infectious disease and, certain surgical ailments, maybe not so as well in cancer management and things like that. So, we should be proud to a certain extent of, the medical advancement, biomedical achievements that have happened. There's no reason for us not to be proud of that. But it doesn't, but I agree with you completely. Ultimately, when we look at what patients need, want, it's communication, coordination, teamwork, empathy. And those are things that we are really poor at, more as a community than individually. but we're not good at it. We are not good at coordinating care. We are not good at those kinds of things. And if you've ever been sick or had a parent who's sick, has one of these complex diseases like a cancer or something like that, you're in this system where you've got an oncologist and a urologist and a radiation oncologist and a radiologist and a primary care doctor and an intensivist and all of these people, and they exist in their own little islands with very little communication, and it's awful to see, to witness somebody who's sick trying to deal with that. And it's not necessarily a failure of any one of those individuals. It really is a system that hasn't put the patient at the center and decided we're going to revolve around the patient. They've created their little sons, and the patient has got this, has to navigate through all these things in essentially a constellation of doctors, which is near impossible. Layer into that the financial things, and it can be really, really bad for patients, and it's a shame.
Yeah. So what I'm hearing is this is a lot of the art of medicine, the art of actually being a human being, to recognize our patients as fellow human beings and just connecting with them at that baseline level, as opposed to turning on our doctor brains. It's really turning on our people brains and being present and bearing witness and being whatever that patient needs at that time. So we kind of talked about the healthcare system and suffering. How do your own personal worldviews impact how you view suffering? Whether it's your own faith or your own the values that you hold true to yourself.
Well, I guess I can start on this one since you've had to start on all the other ones. Unless you want to, I defer to you.
I think you should start.
Okay.
You got the mic.
You have a mic. So, basically, I don't identify as a person of faith at all. I'm an atheist and was a proud multi-generational atheist as far as that goes. So, yes, my grandparents were.
God's coming for you.
Yeah, I got some accounting to do then. No, so but I do very much feel a connection in humanity. I think that we were talking about this right before we started, that I believe that I have an inherent desire, need, interest in connecting with my colleagues, friends, patients. I believe that that's genetically encoded into me because people, do better when we're social animals. We do better when we do that kind of thing. But I believe it, and I think that for me, the meaning of life is what we're going to give to it as humans, and everything that is going to happen on this planet is going to happen because we do the work, and we work together to do that work. And so, that's how my worldview is. And so maybe that's part of the reason I don't shy away from conversations about suffering or end of life, because, I've got to do the work. We've got to do that. Only I'm going to do it. There's nobody, and that's not true. Obviously, other people can do it, but there's no deferring that to a higher power or something like that. It really, the buck is with me, and I'm going to deal with that. So maybe that is part of the reason that that I do these things. Maybe it's part of the reason that I feel like very comfortable giving my medical opinion about things, because I don't think that I don't worry about a higher power that's judging me for having that. I don't know if that makes any sense. But I did want to say one other thing about the medical opinion that maybe will help with the students, just if that's okay. It's a digression.
Yeah.
But one of the big challenges I feel towards giving a really powerful, meaningful medical opinion is uncertainty around your own uncertainty. That's tough when you're a junior learner, when you haven't seen as much, and when you're in an environment where you've seen people with respiratory distress get intubated and then seemingly have less respiratory distress. So it's hard to give those kinds of opinions, and that is going to be your charge over the next couple of years and into residency, to really learn, really understand pathophysiology, so that when you see the patient suffering, when there's limited to no hope for, a reversal into a much better state of affairs, that you'll be able to give that strong recommendation. If you don't know and you're not, and you haven't had the experience and you haven't developed that knowledge base, then it's really difficult to give, these sort of, medical opinions. And I think we really you have to remember that all the time, that's part of the reason you're doing it, not just so you can do a procedure, but that so you can say, no, we shouldn't do this procedure.
I'm going to go back to suffering and atheism, if I may. So I was thinking about this before when we were chatting before we started. And have you ever heard of the writer C.S. Lewis?
Yes.
Okay, Lion, the Witch, and the Wardrobe. Okay, so he was an atheist, and he said that when he was an atheist, he would look at the world, the cold, hard world, and wonder how anybody could possibly believe in a good and loving God. Because the world is just full of so much nastiness. And he was surprised when people would look at the world. This was him in his atheist self. He was surprised when people would look at the world and think that there is good, that there could be a good and loving God. And yet many people do, whether, certainly taking it beyond the human relationality, right, and saying, but there seems to be something out there. And then with regard to suffering, then you get to this question of, okay, well, if there is this something out there that is superhuman, that takes us beyond ourselves, and for some reason, human beings have had this idea that there's this good and loving being, this intelligence, good and loving intelligence, then why does so much suffering happen, right? And Epicurus, like way back, I don't know if anybody was a classicist, I don't even know when Epicurus was alive, maybe, 300? Does that sound good? 300? Okay. Not that you would know, Tim, I don't know, I expect you to know these things, but, so Epicurus says, if God is loving or benevolent, why would God then allow all this stuff to happen? So then God must not be benevolent, but maybe God is powerful. But then if God is powerful, does God not have the ability, the power to stop this? So you end up with this problem of, okay, so many of us look at the world and think there's something out there that is bigger than me. So then why does all of this happen? And why so much suffering in the world? And so, I come from the Christian tradition, and there are a lot of sort of answers put forward to why a good and loving, a powerful and loving God would allow so much suffering. And the big three are, well, maybe suffering happens because it leads to our sort of development as human beings. And certainly, probably if all of us thought hard enough, we could think back to some point in our lives where something was really hard, where we did suffer, but we learned and grew through that. So you could say, okay, well, my 10 hardest years as a primary care doctor made me want to quit medicine at least twice a week. And yet the lessons I gleaned from that 10 really, really, really terrible hard years are lessons I've taken forward that have changed me, but also I think honed me. So some people will say, well, that's an explanation. Maybe this good and loving, powerful God allows stuff to sort of refine us, make us wiser and better people. Maybe. I mean, then there's this question of whether God, if there is a God, allows suffering because of free will. Right, so if you think about designing, or you just think about a relationship, right? If you have a boyfriend or a girlfriend and you force them to love you, then that's not really a loving relationship. And so the idea here is that, well, maybe God allows all this stuff because while God could control it, some of the bad stuff that happens we bring on ourselves. the way we treat one another. And if God just wanted robots, God could design us as robots to do whatever God wants, but instead God gave human beings free will. So that's sort of another explanation. All of the pain that we inflict on one another is because we're sort of given the freedom to do that. And then there's this sort of third common explanation about why a loving and powerful God would allow so much suffering, and that's the kind of idea that there's a big gulf between the cosmos, between the intelligence of the universe and ourselves, right? So you think about, you work in a hospital or a medical school, you're not privy to what the decisions the dean makes or the CEO makes, right? There's a gulf between you and the ultimate authority in any situation. And I'll say, these are common explanations. I think there's probably some validity to them on some level. But ultimately, I think none is wholly satisfying. And so we are left with the idea that, okay, well, if you're not an atheist and you do think there's some intelligence out there who could be good and powerful and loving, still suffering happens. And so then what do we do with it? And that kind of brings us back, right, to, whether it's what Martin Luther King Jr. said, Jeremiah the weeping prophet, you confront your anguish and you bear it, right? This is my suffering, I bear it. And I think certainly one of the threads we've touched on is the idea of needing to do that in relationship, right? Mm-hmm. So whether as physicians with our patients or as you go forward in training, the community that will help embrace you as you get on in your training, because you cannot go through medical training alone in isolation. You need to have a community of support. It's the only way to go on caring well for patients. But we bear our anguish and our suffering together. So I don't know that there's an ultimately satisfying answer.
Yeah.
I guess I'll just say one last piece from the Christian perspective, which is that there's we just came through last week was Holy Week, right? So the idea that in Christianity that God became human, right, in the form of Christ, and suffered this unbearable anguish, physical anguish, right, death on a cross, I think has, through the history of Christianity, given Christians a sense of solidarity in suffering with a God who knows what suffering is. And so maybe that's the strongest argument from Christianity, that God allowed God's self to come in the form of a human to suffer alongside and to suffer and die a human death, sort of the least dignified human death that there was at the time on a cross. Maybe that's the most reassuring thing for people from my tradition.
Yeah. Thank you, and thanks for sharing how your own personal, spiritual, or religious beliefs, or none thereof, shaped how your belief have shaped your suffering. So there's so many great questions that you all have entered. So we're just going to use the remaining time to do our question and response. And it's going to be a little potpourri. There were a lot of questions related to pain and suffering. And I think one of the questions is, what do you think keeps people who are in immense, consistent pain out of suffering, or in a state of response of joy?
Make sure I understand the question.
Let me ask again. Yeah. What do you think keeps people who are in immense, consistent pain out of suffering, or puts them in that state of joy?
Yeah, I think we've touched on this. I think it's like my dad used to say, it is what it is, and only through tremendous work and infinite patience can we change it. So I think that, if having a sense of purpose is really vital to patients, and, when they're productive members of society with families that they're caring for, if they're able to do things, that starts to become the focus that gives people joy in life. And you can do tremendous things in states of intense pain. I think we also talked about the concept of community, helping people, but I do actually really believe that being able to provide care helps a lot of patients or a lot of people who are suffering with pain or other things sort of work through that. That their life still has value because they're able to provide some level of care for other patients or for other people. And that's just something I've observed a lot of.
Okay. I'm going to combine two questions here. So bear with me. How do you approach suffering when you yourself might be in the midst of seasons of your own suffering, or if it reactivates some prior traumas that we've experienced? And then the second question to follow that up is, how do we honorably serve both our patients and ourselves in situations like this?
Those are both fantastic questions. So I do think there's a certain amount of compartmentalization in medicine, right? I remember one day in primary care practice, it's first patient, the guy whose wife just died. Second patient, the woman whose cancer spread to her brain and she can no longer drive and she's like on death's door. Third patient, total social disaster, daughter on drugs, raising the grandkid. And I just remember, I tried to write a poem. I don't write poetry. But it was like, I did not know what to do with that amount of human pain back to back to back. And I had 15 minutes per patient, and I had no gap between patient. I had to keep going. And you have to, you can't walk from the guy whose wife just died into the woman whose cancer spread to her brain and is having seizures now and can't drive. You have to let that guy just sit there and come back to him later. I mean, emotionally, I need to be fully present for this woman in front of me. And so there's a lot of compartmentalization. I will say in residency that, and because I'm someone who wants to sit with grief, it means that you end up taking more on you, right? That's why I said sometimes for self-preservation, you do choose to just walk alongside it, take a little distance from it, not sit with it and stare at it. And I remember in residency when you're working, arguably 80 hours a week, but it would often be more, and you get to your one day off, and that's when suddenly all of this emotion that I felt intensely but had to compartmentalize would come back. And I would usually spend my day off kind of writing and reading and quiet, and I didn't have kids then, and that's another conversation. But it was easier without children to be able to take that space and do that sort of thing. This is where community, having sounding boards, good friend, a partner, right? Some sort of community group, a book club, a church group, whatever it is, right? That community of support is so critical. But the second part of this question, I think that's really important, is what if there is reactivating trauma? And I have had a couple of patients that were so inappropriate. I won't put it because we're recording. Were so inappropriate that I had to I went to my superior, I explained the situation, but I had to excuse myself. This was twice in 25 years, but excuse myself from the care of those patients because of the kind of behavior that was going on. And so there are times, again, it's usually pretty rare, but there are times where either because of the nature of the way the patient is relating, the patient's own messiness as a human being, or for those of you who have had some particular traumas that a patient is sort of triggering, I think there are certain rare circumstances where you may need to ask to have another member of the team care for a patient.
Yeah, well, I'll reiterate that those are great questions and great answers. I'll just expand on the second point you were making. And so in emergency medicine, we do deal with probably more abuse than most specialties, just the nature of the environment. I'll just put it at that. And we know that our staff, the nurses, take the brunt of it. Mm-hmm. But after that, it's the young women doctors that take the most. And last is me, the old white guy. I got a bunch of layers in front of me, so I'm good. But so compartmentalizing and all that is very important. You're going to do it. they're gonna make you do it. You're gonna figure that one out because you're gonna have to. But I think that as a community, we could do a lot better at setting up systems and rules that are enforced so that there's less abuse, since you sort of alluded to that one, towards our caregivers. I think that there is a bit of a fear that if we set rules and patients violate them and we, terminate them from care or something like that, that's a big legal hurdle and we can't really do that and all these kinds of things. And I think that unfortunately what that does is when there's abuse, that you have to completely bear it yourself. And I don't think that's fair. And then you have to develop coping skills, whether they're, prayer groups or yoga, you know what I mean? Like, it's like you have to do it all by yourself. And that's so unfair to all of you and all of us. We have to do a lot better at establishing a space in where a clinical space that's a caring environment. And that cuts both ways. It really does. I have a lot of empathy for patients, and I have a lot of empathy for patients who've lived really difficult lives, but that can't be used as an excuse to allow abusive behavior to go unchecked, and for the system to not have ways to sort of put it in check. And I just wanted to add on that one, that as a community we have to do really a lot better job.
Well, and I really like that, Lydia, both of you actually mentioned community and how community is actually important. So probably the first thing is acknowledging and recognizing, I remember when my dad had a health issue and then I was on call and I saw a patient and admitted a patient with the same health issue and I went into disaster mode. But then half an hour later, I realized I was overreacting because this was now bringing up all of the emotions that I did not exhibit when my dad was going through it. So I think the first step is actually being able to take that step back and acknowledging, is this me overreacting because of something that I myself have experienced? And then being able to sit with it and talk to other people, whether it's our community, whether it's our senior, whether it's our attending, whether it's a therapist, and really just process and debrief. I really appreciate that here at our hospital we had the Second Victims program where, anything that happens, it doesn't have to be a patient death, but any kind of traumatic thing that happens in the clinical setting, there are people there who are trained who can actually help debrief providers in what they've experienced. So I think part of it is actually allowing for ourselves to be human too.
But I think we're really at our infancy in that.
Yeah.
We've now, peri-pandemic, a lot of these things started to show up, and there are programs like the Healing the Healer and all those kinds of things, and that's really important. But I don't think that really at this point has gotten into our, deeply into our culture. And I still think the majority of the responsibility towards figuring out how to deal with your, when something activates you or when someone's abusive towards you, I still think our culture is such that compartmentalize is our answer for everything, and we definitely need to build out those other pathways, because obviously we're not going to be able to take care of people if we can't take care of ourselves.
But compartmentalize, but then you need to do the work of processing it, right? Because
yes,
because then
100%.
and I'm not saying you weren't saying that, but then you end up with, why are we an addicted profession? Why do we have high divorce rates, right? Why are we alcoholics? All of this, I know that's not the right word, sorry. So why is it that we have all of these issues as professionals? And it's because so many, right? We've never been taught these skills, right? And we never institute practices in our own lives to be able to work through the intensity of what we're dealing with. So anyway, yeah.
Well, and and in processing, there are a couple of questions where now the theme of guilt has come up. The guilt of the privileged life that we live in comparison to the suffering that we observe our patients to undergo, or the guilt that comes from feeling like the suffering that we are experiencing feels insignificant compared to those of the patients whom we see. How do you reconcile with that?
I'll just say that I think with all due respect to whoever asked those questions, I think if we're thinking about it that way, we're too much focused on ourselves, right? We have enormous privilege, and even if you grew up poor, even if you're an immigrant kid, even no matter what, the fact that you're sitting in these seats, the fact that you're studying medicine is a position of enormous privilege, however you got here, however hard your upbringing was. And so with that privilege then comes responsibility. So don't focus on the guilt. Focus on how you are going to, with the resources of a community, with your own good practices for processing all of this stuff, become the best physician you can to serve people well. So eyes off ourselves and eyes on the other in front of us, and think about how we can become the best physician possible to serve those in need and develop the practices to sustain us.
How do we do it when we have such limited time with our patients to try to help and alleviate their suffering?
Obviously you can't re-raise somebody and give them their life back and those things. But I think I said in the beginning, you actually can go a long way by just speaking to a person like a person. Like they are every bit your equal on every level. And I do think there's this insidious thing over time with physicians where that right now you guys are like, of course. But over time, I think that actually goes away and you become Dr. So-and-so and they become patient Y instead of Mike and Lydia. And I think that, like, I introduce myself as I say, I'm Dr. Menchine, you call me Mike. That's how I do it. And I usually sit down at the patient's bedside. Partly because I'm lazy, but also because getting on that eye level and doing this, it really, in my opinion, I don't know, you can ask patients, it's, research tends to support this, but it really creates, an even footing, and I think that helps restore some of these, some dignity and alleviate some suffering. And so I think you can actually do some of these things very easily. Without an hour and a half of delving into people's lives experience. And I'm reminded of Father Greg Boyle. I don't know if you Father Boyle, who runs his Homeboys Industries and stuff like that. A really remarkable person. And he told me once, he said, because one of his things is he rehabilitates people who have been hardcore gang members. And he said, one of the things about talking to a gang member is that if you treat them with respect, you'll probably be the only other person who's ever done that in their life besides their mother. It really struck me, and that's a power you have as a person who's, succeeded beyond, any kind of normal measure in life. You've become a physician, you've been trained to become the specialist, and all of those things you have. A standing in the community that most people can't even relate to at all. The fact that you would humble yourself or whatever it is to speak to somebody just like an absolute, with total dignity and total respect, can be a very powerful thing.
Yeah. You guys have probably read the studies that when you sit down at a bedside, patients perceive that as you spending a lot more time with them than you are, right? So that sort of thing. The other thing is respectful touch, appropriate touch. I almost always listen to heart and lungs, no matter, even if they're there with a stubbed toe or whatever, right? But it's an excuse to lay hands on. They feel examined, even if the exam isn't important. And it's not, it's a part of the show. Is it a charade? Well, no, it is, it is building relationship, right?
Oh, I say it in the most loving way. I do it too. I put my stethoscope in backwards sometimes because people always talk through the exam, and if you have it in right, all you can hear is this. And I actually want to hear what you're saying. So but it's part of being a doctor.
One ear out.
You talked about ritual in your book, and I do feel like there's something to ritual in the exam.
Yes.
And this is, if you don't listen with the stethoscope, then they haven't been examined, even though, if it's a stub toe, maybe they give you some grace on that one. But if they have like chest pain and you don't listen to their lungs, you're not treating them with dignity and respect that they think a doctor should do. Now, we know you can't really hear anything, and you're getting a chest X-ray, and you got an EKG, and you did a bedside echocardiogram already, but you put your hand on the shoulder, you tilt the patient forward, you have them take two more deep breaths, and it does communicate something.
Yep.
And it may be ritual, and it may be a show and whatnot, but it's part of it's part of what we do.
It's the art.
It
It's
is.
the art.
It is. And I think that kind of leads into, you've already answered most of this question, but what are some actual things we can actually say when patients express their suffering beyond, I'm so sorry, beyond the things that you've already talked about with regards to showing them the dignity and the respect?
Yeah, I think sometimes just giving patients permission to just talk. Tell me more. Tell me more. Yeah.
I once was interested in I'm still interested in doctor-patient communication, and I went to a linguist who studied this. And I went to one of his talks, and he showed his data and had all these recordings that the average patient is able to speak for less than 7 seconds without interruption for their problem presentation. So when you say, "What are you here for?" within 7 seconds on average, the doctor interrupts to start asking their pointed questions that are going to direct the interview. Obviously, if your family members are anything like my family members and my patients, you can't let them just go on forever. But you can afford 30 seconds. And I've done it. I've timed 30 seconds. Almost no one will talk 30 seconds without another prompt. So, you can avoid the interruption. You can give them that space to say what they want to say. And it costs you like 10 seconds. And frankly, it ends up usually saving you hours on the back end because they actually were able to tell you all their problems, and then you don't have to focus on all these other weird things that popped up because you were too busy interrupting them to let them fully express themselves.
Well, and the interesting thing is there was another study, and I think I shared it with the students during the white coat ceremony remarks, but it takes 52 to 58 seconds to build rapport with the patient. So imagine that, 30 seconds of them talking, 52 seconds of you just engaging with them as a person. And you've built this wonderful relationship that you can only expect to build more strongly upon as you enter into whatever's going on with that patient.
I mean, the key to it's sincerity.
Yeah.
Once you can fake that, you've got it made.
That's a good one. That's such a dad joke.
It's George Burns. So, it's not mine.
So I think at this point in time, I'm going to wrap up our Q&R. There's so many other great questions I want to ask, but we just don't have enough time. But I wanted to invite Miranda and Jasmine back up to close us out. Thank you to our panelists.
Thank you all for having us.